jumped to 200 plus, renal failure on regular dialysis. Female, all reason to make the procrastinating increases, but not that much increase. The procrastinating was around 280. So the lady became obtunded and reintubated again. And this is her lung exam again, which showed that there is still pneumothorax effusion, which looks complicated. This bilateral pleural effusion was drained and found to be exudative parapneumonic effusion. But again, we started our immunology, we sent culture. The culture came positive for ESBL, and the blood was sent waiting for the results, which came later. The 3 cultures are negative, but only the tip of the catheter, central line, was found to have also ESBL. We believe on echo for every hemodynamic diagnostic patient that you have to do echo when the indication appeared again. So you don't rely on the previous echoes of the previous exams. With any change in the clinical setting, you have to do and repeat the echoes again. What you see here is, what do you think about this? This is on March 2. There was this one on admission on February 14, 2 weeks before this. And there was part of this on 2 weeks ago, but then there's another mass attached by transthoracic echo to the anterior mitral valve leaflet, or maybe the B2 of the posterior leaflet. This is the 2-chamber view showing that the mass is sessile, pedunculated, moving with the opening and closure of the valve. Look at this one. It's a very clear, bigger, newer mass. Again, this lady is requiring very high dose of norepinephrine, and procrastinating started to decrease after we added amikacin to meropenem. So we now on meropenem for ESBL, which showed it in sputum, was not in the blood, but it was in the catheter tip. But we thought that based on this, that this is a mass attached to mitral valve for differential diagnosis. What could be the definition? Mass, pedunculated, sessile, the echo people would like to call it like this, and it is toward the low pressure side in the atrium and moves to the vegetation. What else? What other things? Mass attached to the leaflet of mitral valve. By the way, you might see accidentally as what happened with us. Thrombus, myxoma usually is attached to the side of the hip, not to the valve itself, but tumor, calcification. Okay, so based on the clinical scenario that we have, patient who is shocked, a mass which was smaller 2 weeks ago with the clinical deterioration and hemodynamic instability, it became more obvious and bigger in size. These 2 criteria are in favor of one. Somebody who is positive, not yet positive blood, ESBL in the sputum, high dose of vasopressin, very high inflammatory markers. Somebody who is diabetic, hypertensive, old age, renal failure, on dialysis, immune compromised. So this is most likely an infective endocarditis. So we added daptomycin to the regimen, and we see that the mitral regurg on admission was smaller than what you see after the progression of the infective endocarditis. The mitral valve regurg became more obvious, let's say severe mitral regurgitation. Another sign that this valve was destroyed by vegetation. And actually, what destroys the valve more commonly is the vegetation compared to thrombus and compared to calcification. Usually, calcification doesn't destroy the valve. Again, you can see here that time of this is, if you compare, this is the first examination when the patient came, and the first to ICU, and this is on 2 days after. We do routine echoes for our patient, maybe almost daily. And this is when she became in septic shock with very high procalcitonin and inflammatory markers. Look to compare. So this mass is increasing very significantly, pointing toward the vegetation, and actually with adding amikacin, daptomycin, the procalcitonin drop and continue to drop till it reach less than 4. You might have culture negative endocarditis. Blood culture negative endocarditis is possible when you have previous antibiotic exposure. And our patients in ICU, in almost 100% of them, they receive an, some people they call it wedge. And once patient in ICU, he or she antimicrobial. This is totally mistake. Should not be practiced. If you have indication, you give. If not, don't. Another differential diagnosis of culture negative is a fastidious organism, and including the fungi. So this might be culture negative. By the way, blood culture might be negative in up to 50% of septic shock bacteremic patients. They might be negative culture. So keep in mind that negative culture doesn't rule out presence of vegetation or significant endocarditis. So this is, if you look carefully, you're going to see that this, the last one, is on 8th of March, and the mass, this is on March 5, this is March 2, with days of antimicrobial, the mass size is reduced. By the way, I have to thank Najwa, Spitford Hospital, one of the best echo technicians I know for the last few years, because she was very patient doing the exams with us every day. By the way, we do in critical care our exams, but the backbone for you is the cardiology department. You should not forget this, that once you suspect something and you're sure of, you lose nothing to consult them. And you lose nothing to bring people to health, because they know better, they saw more than others. And this will give you more experience contacting with people who are investing in this field. So, and again, in critical care, we do focus goal-directed exams. We don't go with comprehensive full exams, and just you direct attention toward a direction in favor of the patient's health. This is very important. So with the time, you see, this is maybe on 12th of March, you see how regressive is the mass of this lady. And here, you have to bear in mind that regardless of any country, echo is mandatory when you look to diagnose. Because the echo is not only to see the mass, but the echo is to see if the valve is destroyed with this mass, and if the ventricle are dealing with this mass in a normal or abnormal way. Is this patient cardiogenic shock and infective endocarditis, and the involved valve is with regurgitation or not? This makes a huge difference in the decision to go for surgery. This is very important, and this is why we have to go with echo. And the echo, transthoracic echo is sensitive, as Dr. Walid mentioned. Difference between sensitivity and specificity. Here, TTE is only 33% sensitive. So you might have up to 70% of negative transthoracic echo by patient. While the transesophageal is sensitive for the 90%. And this is one reason why it says that every intensive care, every unit should have a probe dedicated, TTE probe dedicated for us. Because you need to do your own. And specifically, if you have to decide Echocardiography, you should start with transthoracic echo. But what if you don't have the use? In up to 30% of cases, you don't see anything. Then, or if you have a prosthetic valve is indicated for transesophageal echo, even if you see any other. Another point, which is when you have negative in a suspected case, you have to go with. This is the protocol of the echo engineer, either transthoracic and or transesophageal echo. But you have to have the indication very clear in mind. These are the indication of EE, because when we take the opinion of people, they would say, if you have a mass here of transthoracic, why you go with transesophageal? Just to play with the tool? With the toy? No. Transesophageal echo gives you more details that the transthoracic will never give. One of them is that you have to see other bags. As we mentioned before, presence of negative bag of transthoracic, the aortic bag, it might be involved. This is number one. Tricuspid valve might be involved. So with transesophageal echo, you see valves, and clearly you can say that other valves. Another important point for transesophageal in such cases, which appear very low in transthoracic, is to see the extent of damage. The paravalvular area. Is there a damage to the paravalvular area? Is there abscess formation? Is there perforation of the left lid or not? All this by normal transthoracic. Because I've been asked several times, you see the vegetation of the why you go with transesophageal? So I hope this is very clear. As you see here, and I wanna hear from Dr. Hisham, what do you see about this leaflet, Dr. Hisham? See, this is the mass which is attached to the posterior mitral valve leaflet, but you can see something which is ring-shaped on this valve here, Dr. Hisham. Looks an abscess or a calcification ring attached to, so there is a differential diagnosis. And this might be a fungi affecting this posterior leaflet. It's not only a mass, but this leaflet is destroyed by the infection. And actually, you have to keep in mind that team has to come bedside. This team has to involve again the cardiologist, cardiac surgeon, and the echo expert. Again, we are not here to replace the other body's job, but to give them the hand that this is has to be very, you shouldn't be very, very eager for it to think that we basically, we have to know our capability and have to give it. This is another very important point with the TE study, that you see, if you believe that this was a thrombus, you have to see other common sites of thrombus, which is the left atrial appendage. If you look at this patient, this is the left atrial appendage, this is the left atrium, this is the mitral valve, and here is the appendage. We open the appendage on 100 and we fire the color. You can see that the appendage does not collapse with contractility. One, doesn't take color. Two, and the third is that the flow in the pulse wave Doppler flow in this appendage is very sluggish. The criteria which suggest presence of left atrial appendage thrombus. But again, this might be concomitant with vegetation, which everybody believed that this was the top differential rate. By the way, sometimes you need to go and open and see the vegetation yourself. We referred and they discovered the differential diagnosis for the mass and aortic valve. Once they opened, they said, this is nothing but vegetation, fungal infection. You can see here that there is a mass in the IVC with a post-hyperechoic shadowing here, indicating that this is probably an inferior vena cava thrombus as well on the same patient. This is what I said, why the patient of infected endocarditis might be in ICU. We should be very vigilant to this. Any patient with septic shock might be because of infected endocarditis. And the infected endocarditis will complicate with septic shock, cardiogenic shock, and most important, neurologic complication of sequelae, especially on the left side valves. This has to be in mind that the mortality, despite the surgery, is very high. We have to know when to call the cardiology and when to call the cardiology. Significant vegetation with a mass above 1 centimeter by 1 centimeter is steroid involved that associated with regurgitation, associated with shock, cardiogenic shock. This patient needs surgery and as soon as possible. Another case, which is 19-year-old admitted to the floor with fever and found to have this chest X-ray. This is the chest X-ray on admission. Young, female. This is nothing, but it's an artifact. Female, feverish, high white cell count, bilateral infiltrates, pneumonia. And then while in the floor, she deteriorated and they called ICU, fortunately. Because we saw her like this, we intubated her and she was in bad ER. Young female, admitted with fever, chest X-ray. Has no past medical, intubated, and with this aggressive chest X-ray, everyone believes that this is a pneumonia and no other differential diagnosis. Look at the lung on the lung ultrasound. Very severely collapsed, consolidated lung with small, very consolidation effusion, as you see here. Very severe consolidation. The whole lobe is consolidated and collapsed. Now, review here, you can see maybe Al-Ab Nariya. You see this one? See? This is air bronchogram. The air is going in and out when this feeding loop, when this feeding bronchi are still patent, but some of these white dots are not fading, are not going away. So this is the goes and back is dynamic bronchogram, the pathognomonic for consolidation, and the fixed or static dots are for collapse. So no doubt that we are dealing with ERDS by lung ultrasound, by chest X-ray, and she's very hypoxic on 100%. Actually, she was young and she was turned prone with minimal response to bone. Still, refer to ECMO, where we have an intelligent Paris, who used also to use the ECHO, is our senior registrar, the unit, and we in our unit we routinely do echocardiography to see the heart for any respiratory problem, and we see the lung for any cardiac problem. You lose nothing, but you might gain a lot. What Dr. Faris saw once he put the probe is what you see here. What valve is this? This is the aortic valve, and there's a big mass attached to aortic valve. See? And again, with the severe aortic regurgitation, patient is in shock. If you look at the left ventricle, you see that the left ventricle is moving very badly. Is it septic cardiomyopathy or cardiogenic shock with this big mass you see attached to two leaflets, two cusps of the aortic valve? The coronary left and right coronary cusps. So, again, with transesophageal echo, we see the mass very clearly. So this is infective endocarditis, not only ERDS. And actually, if you keep doing whatever you do, and actually you might transfer for ECMO, and somebody will attempt to do it, and insert lines and every single effort, maybe until like when this girl start to be shocked. Why? If you don't look at early at the beginning to see this mass, yes, another issue. Yes. But there is a major issue. This was referred and said this, and she went into surgery within a day or less, maybe, and they found a big vegetation, fungal vegetation, aortic valve malformation. She died on the table or immediately after. But again, routine echo is mandatory in every patient. You might say something that is not at all in your mind. Thank you very much. 5 minutes, because we are very hungry. Mr. Joel, the companies, Baxter, and actually we really appreciate the effort of companies to support our meetings because we are poor, cannot support these meetings. Okay? And very, very for the people who are attending online. We have almost 40, and we are very thankful to Dr. Walid and effort behind the lecture and presentation.